respected past presidents, senior members, office bearers, and my dear friends, I welcome you for our IMA meeting today. I request Dr. M.B.B.S, today's speaker, past president, on stage please.
Past presidents, senior doctors, colleagues, friends. Firstly, the new membership drive, we've had 2 members and taking the tally to 2,190, and we are, I think, 1% of us are here. So I think the corona effect is still not over. The new live single members, 3 of them have joined, and it takes the total tally to 665. Family Security Scheme 1, 691, and Scheme 2, 173. And we had a lot of events in the past 2 months. On 8th of March, we had the Women's Day at Gokulam Hospital. It was attended by a score of dignitaries. Our past president, Dr. Chennamal, Dr. Rajesh, NSP coordinator, and a lot of others were there. And on 13th March, we had International Women's Day at IMA Hall celebrated, and the chief guest was Dr. Chennamal ma'am, and a lot of functions were there, Mehendi and few others, which singing competition, solo, and all these things. I had one suggestion from doctors to get more crowd. Ladies club and children, if they are activated, more crowd will come. Definitely, I take that point, sir. And also journal club. So these are some of the things which we will start doing. On 20th, we had Women's Day celebration. IMA and Joe Salukas celebrated on 20th. And 20th again was State Council meeting of IMA at Kallakurchi, and a lot of our doctors, senior doctors attended the meeting. On 27th, IMA Cgp CME program, Dr. Manivannan sir had conducted it, was very nice. And then a new team of office bearers were installed on 2nd April. So before that itself, we started doing a lot of activities, and for that our state president had come, Dr. Palnisamy sir, and state president-elect Sendamal sir had come. So it was a nice function. On the same day, Dr. Shivashankar had given a CME program, our gastroenterologist and treasurer, who will be joining us soon. And on 2nd April, All India Protest Day and press meet was held, wearing black badge for justice of Dr. Archana Sharma, Stop Violence Against Doctors, and Dr. Sendamal Pari participated in that as well. On 10/4, we had a Nursing Day celebration, for which our Nursing Home Board meeting was held, and for which Dr. Karthik Prabhu, Chairman Nursing Home Board, Tamil Nadu, was here, and he gave a very good address. Close to 100 doctors, administrators participated in that, and few others. Even our collector was there for Nurses Day celebration, for which the hall was fully packed, and it was overflowing, in fact. So that was one nice event. We plan to have next week. We plan to have a cultural program in IMA. So that will be for all ages. It will include singing, dancing, competitions, singing competition, dance competition, then stand-up comedy, videography, photography, short films, and environment and social impact awards. So these are some of the things, and this will be an audition, and 5th will be the finale at Sauna College. And this program is being recorded, and we have a YouTube channel called IMA Salem 2022. Already there are videos uploaded on that. So please open your YouTube, go and type IMA space Salem 2022 and subscribe that for a lot more doctors who are going to be giving their videos, which will be useful for doctors and for general public. Thank you.
Good evening, one and all. Respected President-elect Dr. Panniyappan, Secretary Dr. Sashi, and our senior members of Salem IUP, and my dear colleagues and friends. Today's topic is fluid balance in diabetes. So basically, the pediatrician or pediatric oriented doctors, we usually hear from the mother that the baby has diarrhea, and we gave glucose solution, and the diarrhea didn't stop, and in fact it got aggravated. So that is an artificially induced diabetic mellitus in pediatrics. Giving glucose alone will induce osmotic diarrhea, and the baby lands up in the complication. So with that base in mind, we'll proceed with the topic. So the need for adequate hydration in diabetes, especially during summer and diarrhea and viral fever also. So the viral fever season is again, and probably we have crossed another virus, but fortunately it didn't touch about the hydration part. It was touching the lungs more. But the high fever, what we are expecting during the June to December, will be dehydrating the patients more, and managing hydration in diabetes is very important. Next. So the objective is to understand the hydration status in patients with diabetes, understand the dehydration, the electrolyte imbalance in patients with diabetes, and understand to prevent and treatment of the dehydration in patients with diabetes. So we'll take a small case presentation and we'll move on to the discussion. Next. The 58-year-old male with type 2 diabetes, he presented with temperature of 100.4. He had viral fever for the past 4 days. He had an altered mental state, and upon questioning, he reported unquenchable thirst and repeated need to urinate. So he has presented with to the emergency department of the same hospital 7 days prior with the complaints of mild abdominal pain. So abdominal pain is one of the common presentations in diabetic with dehydration, especially going in for DK. The patient had an elevated plasma concentration of urea nitrogen and elevated hematocrit, findings that support the observation that he was dehydrated. His blood pressure was 100/60, heart rate 120, and weight 54.1 kg, and his mucous membranes were dry. So initial laboratory test showed the sodium was high, so that he is hyperosmolar, hypernatremic, and hyperosmolar. The blood sugar were also high. HbA1c was 9.9. So the initial serum osmolarity was 445. The normal range we know it is around 285 to 295. The paired urine osmolarity was 811, and normally it is between 50 to 1200. The urine sodium was 41 millimole per liter. So managing the case, the ABG was taken hourly for the first 48 hours, and specifically tracking sodium, chloride and glucose. The potassium level were in normal range. And basis the estimated water deficit in the first 12 hours, 2.7 liters of fluid was given using isoosmolar formula via the enteral tube feeding method. Once the patient was stable, electrolytic was provided for dehydration and to help fasten the recovery process. So post-management, the patient showed recovery from day 4 onwards. His weight increased from 54.1 kgs to 72.5 on day 9. So he has almost lost 18 kilos of his weight because of the dehydration. And 2 months later, when the patient came for baseline for the follow-up, the baseline function was normal and he was performing his daily normal activities. So how hyperglycemia influences the hydration status in patients with diabetes? Elevated glucose exerts osmotic pressure, which elicits an internal shift of the body water from the intracellular to the extracellular stage. Increased risk of dehydration through the urinary water losses and elevated arginine vasopressin concentration and the risk of hypovolemic hypoosmolar state. The studies, next. So the low water intake risk for new onset hyperglycemia, and it was published in 2011 in Diabetic Care. The conclusion was the water intake was inversely and independently associated with the risk of developing hyperglycemia. Vasopressin is an important factor in the glucose homeostasis, and low hydration status alters vasopressin secretion. Next. So the vasopressin, which regulates the glucose homeostasis in many ways. We have V1A receptor and V1B receptor and V2 receptor. So the V1A receptor through the renin-aldosterone angiotensin pathway, and V1B receptor through the glucagon, insulin, ACTH and the corticosterone pathway, and the V2 receptor with the water recruitment. It all maintains the glucose tolerance. So the low water intake alters the vasopressin secretion, which is an important factor in the glucose homeostasis. The reduced water intake deteriorates the glucose regulation in patients with type 2 diabetes. So here a small study with only 9 patients, and the conclusion was the 3 days of low total water intake acutely impairs blood glucose response. Next. So when we go into the water homeostasis, next. So the regulation of water, normally we have the insensible water loss through the sweat, respiration, urine and feces, and it may be hypertonic or hypovolemic. So hypertonic means the osmoreceptors plays a major role, and in hypovolemia, the baroreceptors plays a major role. So both of them, they produce thirst, and through the renin-angiotensin-aldosterone system, the water intake or the water metabolism is altered. The 2/3 of the water in the body is intracellular, predominantly in the lean tissue. And of the remaining 1/3 of the body water is extracellular, and of the 25% intravascular, only 88% of the total body water is represented. The decline in total body water and with aging leads to the increased vulnerability in older patients. That's why the older patients, when they get dehydrated, the first thing we have to correct the hydration rather than the diarrhea. Otherwise, the hemoconcentration occurs, the chances of getting a stroke or the cardiac events are high in older patients. Multiple sites in the brain are involved in the regulation of the thirst, where the opioid receptors, they play a very major role. The day-to-day regulation of fluid intake is under the control of osmoreceptors. A decrease in opioid system activity that has been shown to play in decreased thirst in older patients. Again, the understanding the water homeostasis, where hyperglycemia increases the serum osmolarity, which results in movement of water out of the cells and reduces the serum sodium level by dilution. So the water balance is maintained by arginine vasopressin, as we know, and the thirst mechanism and kidneys plays a major role. Daily, normally 170 liters of urine is filtered in the glomerulus, and majority is reabsorbed, and only 1% is excreted as urine. Polyuria and polydipsia can occur due to genetic and acquired causes that affect the secretion of action of the arginine vasopressin or the ADH. The osmotic diuresis is caused by excess urinary solute, typically non-reabsorbable, that induces polyuria and hypotonic fluid loss. So uncontrolled diabetes mellitus can induce hypovolemic hyponatremia due to osmotic diuresis. In diabetic ketoacidosis, ketone bodies obligate urinary electrolyte losses and aggravate the renal sodium wasting. Next. So the dehydration could be of two types. One is due to excessive water loss, and another type is due to excessive salt loss. So the water loss, we have to replace this with the hypotonic fluids, and when the salt loss is more, we have to replace it with isotonic fluids. So dehydration is defined as the complex condition resulting in reduction in total body water, and it is due to water deficit, either hypernatremia or hyponatremia, where it occurs in presence of hyperglycemia. So dehydration due to salt and water deficit is hyponatremic, and it is rarely isotonic. So the importance of water intake in type 2. Next. So the low water intake stimulates the secretion of copeptine, which potentiates the CRH action and results in increased ACTH and cortisol secretion. So through the pituitary, the ACTH and the cortisol increases, the insulin increases, and the glucagon, as well as the increased glucose output. And the increased glucose output again due to the gluconeogenesis and the glycogenolysis in the liver. So drinking water may lead to reduced risk of having type 2 diabetes mellitus through it lowers the blood glucose level and improves the glucose metabolism. It offsets excessive water loss from polyuria, several other health benefits outside of hydration for individuals in type 2 diabetes mellitus. So reduced water intake deteriorates the glucose regulation in the patients. Study shows that drinking water more than 0.5 to 1 liter water a day lowers the risk of developing hyperglycemia. Understanding the symptoms and causes and contributing factors in diabetes mellitus. So the patient is usually always thirsty, and he has headache due to dehydration, dry mouth and dry eyes, and the dry mucous membrane. And because of that, the dizziness, tiredness, and even confusion also will be there, and the urine will be yellow and dark colored, and it will be small volume. The volume of urine will be reduced. And the blood pressure is low, sunken eyes, and the rapid heartbeat. Normally it is above 100 per minute, and the patient is feeling confused, and the pulse will be very weak, and the patient will be very lethargic, and probably he will be having even altered sensorium. Next. So the causes, as already we have seen, it may be due to insufficient fluid intake, strenuous exercise, high blood glucose levels, and alcohol, diarrhea, vomiting, as well as high fever, and diabetes insipidus, another clinical condition. Diabetes insipidus, another clinical sufficiently. And potassium disorders, it may be renal and gastrointestinal loss, reduced tubular secretion, and reduced tubular secretion of potassium. Hypomagnesemia, recurrent metabolic acidosis, increased gastro and renal magnesium losses, glomerular hyperfiltration, diuretic administration, poor dietary magnesium intake. And the calcium deficiency is due to hypocalcemia, vitamin D deficiency, acute renal failure, concurrent hyperparathyroidism, phosphorus disorders, malabsorption syndromes, osmotic diuresis, acute renal failure with hyperphosphatemia. So the type of dehydration, as already we discussed, it is isotonic dehydration, where balanced loss of water and sodium, which is normally rare, and vomiting diarrhea because of the large amounts of water and electrolytes in gastric contents. And hypertonic dehydration, if the water losses are greater than the sodium loss, and fever results in loss of water through the lungs and the skin. And it is perhaps the most common cause for the hypertonic dehydration. And hypertonic dehydration may occur where the sodium losses is exceeding the water loss. So this occurs primarily due to overuse of diuretics causing excess loss of sodium. So treatment, the supplemental oral fluids may be is a very important one, and encouragement and close observation are required to ensure adequate fluid intake and prevent dehydration. To maintain the hydration, minimum of 1500 to 2500 ml of fluid will be given daily. And the patient requiring enteral feeds, supplemental free water should be provided. And variety of liquids, especially balanced with glucose and sodium, is very important. Giving glucose alone will aggravate the condition rather than reduce the condition. So the enteral formulas, IV solutions, can be used to replace the water loss. And carbohydrate electrolyte solution may be also very beneficial. So the key points: ample amounts of fluids are important to prevent dehydration, and hence supplemental oral fluids may help. In patients identified as being at risk for possible dehydration, an interdisciplinary care plan with regard to prevention of clinically significant dehydration is critical if the maximum benefit is need to result. And hyperglycemia influences the hydration status in patients with diabetes, since the disease may alter fluid reabsorption in the kidneys. And for patients requiring enteral feedings, supplemental free water should be provided. Thank you.
It is important along with other things. Meals also contains the rice or the rasam or water we take inside, or vegetarian, non-vegetarian. All meals also contain water content itself. So maintaining the hydration of individual. How much of fluid you are talking about? Fluid or water content? Here, children or adult and old age, how much is intake? Because I heard the urologist say 3 liters every day is important, 3 to 4 liters. Somebody says 2 liters is important. What is the 2 liters or 3 liters? Is it only fluid or the water content or everything inside 21 hours? How much is normal to maintain normal health? How to diagnose the dehydrated fluid instantly, immediately, and so suppose we feel hungry, that also comes as thirst also is there. That thirst means dehydration or not. Just explain.
Yes, sir. Actually, the urine output will say about your dehydration status. And when you assess the patient clinically, the dry mouth and the sunken eyes and the skin turgor is also very important. And when you are able to see the tongue, and definitely the dehydration status will be known. And the patient himself knows how much volume he has lost through the diarrhea. So approximately he can tell you what is the loss of water. So we can accordingly start replacing. But initially we have to replace it with both water and salt, because the insensible water loss through the lungs and even the skin and through the urine, all these things will contribute. And of course, the climatic condition is also very important. Yeah, so there is no fixed rule that we have to take 2 to 3 liters. It all depends on the condition of the patient. If the patient has severe diarrhea and severe fever, definitely the water loss will be more. And in children, we normally categorize them as a mild dehydration and severe dehydration. Okay. So accordingly, we have to plan the water requirement, and of course we have to replace it with the salt. That is also very important. So it is the interdisciplinary observation of the patient, and we have to be very careful. So if it is a very mild dehydration, we can manage it the OP itself. But when we assess the patient has severe dehydration, it is important that we have to admit the patient and we have to provide them with the parenteral fluids. Then only then we have to switch over to the enteral fluids and the oral intake. So clinical improvement, and of course we need to depend on the test values of the sodium and other electrolytes.
In lighter vein, என்னுடைய ரிலேட்டிவ் ஒருத்தர் இருக்காரு, டாக்டர் கணேசன். நான் இவ்வளோ ஹெல்த்தியாக இருக்கிறது என்ன காரணம் தெரியுமா? காலையில் எழுந்தோடனே 2 லிட்டர் தண்ணி குடிப்பேன்னு சொல்லுவார். ஓ அப்படியான்னு சொல்லுவார். ரீசென்ட்லி ஃபவுண்ட் இஸ் a severe diabetic. 2 லிட்டர் தண்ணி குடிக்கிறதா நான் நல்லா இருக்கேன்னு சொல்லுவார்.
Very nice basic presentation, Dr. Muthukumar. We are all clinicians, but you told all basic aspects, whether like first year physiology, எல்லாமே more or less we understood very complicated, very complex things you have told there, and you have described everything. But anyhow, what is the take home message to the our patient? We are all clinicians. சார் சொன்ன மாதிரி ஒரு நாளைக்கு எத்தனை லிட்டர் தண்ணி குடிக்கிறீங்க அதான். ஸோ what are the thing clinically? Most of the patient ask the basic question only: how much water I can take, how much water I have to.
Sir, normally I used to say ஒரு 3 sign வந்து water intake adequate-ஆ இருக்கிறதா பார்க்கிறதுக்கு. Number 1 is you have to pass urine every 3 hours, and when you pass urine, it should be straw color or mild yellow color. It should not be concentrated, and you should not feel the pain of urinating. So when you adhere to this basic clinical things, probably you will be able to manage the dehydration.
That's why you take adequate water, it will actually take in all systems, not only diabetes, cardiovascular, kidney, and all this nephrology and psychology. So what you did, very nice presentation, that will be useful for all that, even basic is from solve. Thank you.
Sir, one question from my side. இப்போ lot of patients எங்க கண்ணில் வந்து ட்ரை ஐயோட வராங்க. ஸோ அந்த ஆயில் செக்ரேட்டிங் glands itself are totally blocked. ஸோ அவங்க வந்து தண்ணி குடிக்க சொல்லிட்டு இருக்கேன். Now the ORS எடுத்தா அவங்களுக்கு அந்த ட்ரை ஐ சரியாகுமா?
Sir, ORS actually it contributes or it provides us the glucose as well as the salt. And dry eyes may be due to the dehydration. So dehydration, for that we have to take adequate water. The only thing is the dry eyes normally we come across with the IT professionals. They are sitting always, and especially in the AC room, where they don't get thirst at all. If at all, if they feel thirsty, and they take more of this carbonated aerated water, which is very high in zero calories, providing empty calories, but providing high amount of sugar and all this. So that itself will contribute to the dry eye. So as we advise them to take care of this computer vision syndrome, along with that we have to ask them to take care of the hydration status and see that they take at least 3 liters of water every day. And as I told, with all these three, clinically, the urine output, the irritation, and the color of the urine. This will make sensible water intake. Thank you.
RO water, what is the area? RO water.
RO water, nallada, kettada.
Nallada, kettada. Is there any deficiency? Because of RO water, deficiency of the electrolytes will be there. That's why I asked.
Sir, personally, but what they say is RO, it removes all the minerals from the water. So definitely, that will, in the long run, definitely the patients will have problem who is taking RO water.
So regarding alternate sir, alternative சொல்லிடலாம் ஏன்னா வேண்டாம் நிறைய சொல்லிடுவோம் ஈஸியா அதுக்கு alternate
only carbonated water boil and take it. If you are boiling only, it will not, the electricity will not go.
Hello sir, UV filters are there.
Sir, UV filters, the what the earlier days, these reverse osmosis. UV filter is different from this one. Both they are.
You mean aquaguard?
Yeah, aquaguard was the UV filter. Now this reverse osmosis is different. It takes away the all electrolytes.
So aquaguard
sir, RO UV filter sir. UV filter you can take sir.
UV filter you can take.
UV filter.
Not RO.
That's why
I am telling you.
RO removes all the minerals. Yeah. So in long run, definitely it will be a problem. The only beneficiary will be the fluoride thing. So the fluoride
beneficiary will be for the company. Only beneficiary for the company. That's all. Regarding the old age people or elderly person with the diabetes or anything, their thirst will not be there regularly because of the age factor as well as this one. So they have to take frequent water.
Whether they are thirsty or not, குடிக்கணும் தண்ணி.
தண்ணி குடிக்கிறதுக்கு ஆள் இருக்காது. இல்ல குடிக்கல. தண்ணி குடிச்சாலே பிரச்சனை. நமக்கு தண்ணி குடிச்சாலே பிரச்சனை. அதனால வந்து what they will tell you. That is regular tea or soup or some liquid அந்த மாதிரி எடுத்து சொல்றாங்க. Geriatric journalல வந்துருக்கு.
Sir, that's the opioid receptors. Other than the main. So as the age declines, the opioid receptors also decline. So the thirst itself will not be there for them. So generally அந்த old age patients சொல்றது தண்ணி குடிங்க என்ன சார் தாகமே எடுக்க மாட்டீங்கன்னா நீங்க வந்து தண்ணியை தனியா குடிக்காதீங்க மருந்து மாதிரி குடிங்க 1 மணி நேரத்துக்கு அல்லது 2 மணி நேரத்துக்கு ஒரு தடவை 1 டம்ளர் தண்ணி குடிங்க. I think as a medicine it will help you to prevent dehydration. Because in elderly patients, as I discussed, the chances of hemoconcentration and getting stroke and heart events are more with geriatric patients. So we have to be very careful with that also.
Since there is something related to diabetes, ketone bodies measure பண்றதுக்கு நம்மட்ட ஃபெசிலிட்டி இருக்கா?
யூரின் இருக்கு.
யூரின் டிப்ஸ்டிக் வேற
bloodல இருக்கு.
இல்ல bloodless. Do you have equipment?
Yeah, there is no equipment, but there is a separate test is there.
Is it done here?
Yeah, it's done here. Blood ketone.
Something like glucometer.
Yeah, glucometer. Yeah.
Sir, it is there, sir.
Yeah,
Available. All instruments are available to just like
Measure ketone bodies.
measuring for ketone bodies. So available. And returning to the speaker, sir, excellent presentation. And as you said in your slides, because of the hemoconcentration and they are prone to get a stroke. Especially many of the patients they are getting from dehydration also, and especially in the summer season. Moreover, this dehydration is all seasons problem. Especially in the summer, what happens? The normal fluid loss from the skin and lungs is actually 300 to 400 ml. Summer it is double. Especially because the humidity in the we are also prone to get dehydration. When you are at the consultation room, we are just wearing the mask and not taking adequate water. So what I advise to the patients also is keep 1 liter bottle in front of you. Just take intermittently every 1 hour at least 1 tumbler of water, or just see what is the level you are taking. At least you should finish with 2 liters. Better is 3 liters, but in busy practice we ignore to take fluid because Usually when you wearing mask and all, especially it happened the COVID time. We are wearing all the face shield and everything, we ignore, forget to take. And also, the patients when he is already dehydrated, when going the sunlight heat, they are supposed to get more going to get the heat stroke also, apart from dehydration stroke. And apart from this, even from a patient who had a mild head injuries, they ignore. They prone to get diabetes insipidus. So diabetes insipidus actually, diabetes is the more chances of getting dehydration. There are so many varieties of diabetes insipidus. Mild head injury, they neglect. So whenever I ask the history, that I will also ask for these symptoms, as he pointed out rightly, and urination also, again having dysuria. Excellent presentation.
So the busy practice na probably unga nurse kitta sollite every 5 to 7 patients ஒரு டம்ளர் தண்ணி உங்களுக்கு கொடுக்க சொல்லுங்க.
அவங்க சந்தோஷமா இருப்பாங்க. பரவாயில்ல பாத்துக்கலாங்க.
நம்மள எடுத்து குடிக்கிற நர்ஸ் கொடுத்தா நல்லா குடிக்கும். Yuvraj.
Yeah. Next I call upon Dr. Yuvraj sir to give about RSS Team I 2022 in October.
Secretary Kumar, President. Today I want to discuss not clinical, it's a conference. You can see the RSSD screen. The RSSD is a research society for the study of diabetes in India. It's a golden jubilee and national conference. After 10 years is going to be happen in Chennai. After 10 years. So I am the local organizing committee. So that's why I want to encourage our Salem IMA members to involve this. Most of the எல்லாருக்கும் இந்த ஃபார்ம் கிடைச்சிருக்கும். அதில் பார்த்தீங்கன்னா free life membership. That is only that is. If you pay 5,000 rupees, you will become free life member, and the conference is free of cost. That is a very, very encouraging early registration. Kindly avail this opportunity. We allow the enroll life membership and enroll money. Most of without knowing diabetes, I think nowadays practice is very difficult. So everybody has to know the basic aspect of the diabetes. எல்லாமே என்ன 10 பேர் வந்தா 8 பேர் டயபெட்டிக் பேஷண்ட் ஜிபியில் வருவாங்க. முன்னெல்லாம் வந்து இது ஸ்பெஷாலிட்டியாக இருக்குது. பட் each and every doctor should know basic and how to treat the emergency and maintain the thing. ஸோ அதனால இதில் நீங்கள் அவசியம் நீங்கள் வந்து என்ரோல் பண்ணி இந்த மீட்டிங் அட்டன் பண்ணி you kindly enlighten your diabetic scientific piece. Thank you very much. Thank you.
And Secretary Dr. Yuvraj, ஒரு கேள்வி கேட்கிறேன். இல்ல 2 + 2 என்ன? What is the answer? இல்ல ஏன்னா BBLS சம்பந்தமா பேசுறேன், அதனால அந்த கேள்வி. ப்ரொஃபஷனல் ப்ரொடெக்ஷன் லிங்க்டு சோசியல் செக்யூரிட்டி ஸ்கீம் அப்படின்னு நம்ம IMA the scheme is against அதாவது டாக்டர்ஸ் மேலே against ஆஃப் பேஷண்ட் வந்து மெடிக்கல் நெக்லிஜென்ஸ் கேஸ் போடுறாங்க. இந்த அபாய நோட்டீஸ் அனுப்புகிறாங்க, போலீஸ் நோட்டீஸ் அனுப்புகிறாங்க, கோர்ட் சம்மன்ஸ் வருது, கன்சூமர் ஃபாரம் வருது, சிவில் கேஸ் வருது, கிரிமினல் நெக்லிஜென்ஸும் வருது. இல்லை அதில் ஃபர்ஸ்ட் ஹையஸ்ட் வந்து ஓகே தான், செகண்ட் வந்து ஆப்டோ, தேர்ட் வந்து ஜெனரல் சர்ஜரி. சார் இல்லை நம்ம டேட்டா சார் டேட்டா as per தமிழ்நாடு IMA ஸ்டேட் லெவல் வந்து இப்போ BPL I want to introduce myself. I am Dr. M.B.B.S, Secretary of the PPLS scheme, IMA Tamil Nadu State Branch. Sorry for the late coming. And this is why I want to insist on this, because what science Dr. Yuvraj 2 + 2? Sir, நீங்க சார்
சேஞ்சுக்கு 5 சொல்றேன் பயாலஜிக்கு ஒரு சொல்றேன்னு தெரியல
சார் நீங்க இல்ல 2 + 2 எவ்வளவு கேக்குறேன்
22
இல்ல why because we doctor we should not say 2 + 2 is equal to 4 because if you ask a computer person 2 + 2 in between 3.9999 in between 4.111 சொல்லிடுவாரு அவ்வளோ அக்யூரேட்டாக கம்ப்யூட்டரில் you can give an answer. If you ask a lawyer அந்த லாயர் என்ன சொல்லுவாரு அலகாபாத் கோர்ட்டில் சிசி நம்பர் 448 1977 224 அவங்க சொன்னாங்க. மெட்ராஸ் ஹைகோர்ட்டில் சொன்னாங்க அதனால நானும் 224 சொல்கிறேன் அப்படின்னு வக்கீல் சொல்லுவார். But if you ask a doctor, 2 + 2 is not always 4. Sometimes it may be 0, sometimes it may be 1, sometimes it may be 2, or sometimes it may be 3, or sometimes it may be 4, even more than 4, 5 இருக்கலாம். ஒரு சின்ன எக்ஸாம்பிள், ஒரு இது வந்து டாக்டர் வரதராஜன் சொல்லி நரசிம்மம் போர்ட் செக்ரட்டரியாக இருந்தவர், டிபிஎல் ஸ்டேட் பிரசிடண்டாக இருந்தவர். நம்ம அவர் சொன்ன இதுதான் ஒரு டங் டை ரிலீஸ் வந்து பண்ணிக்கிட்டார். அவருடைய மெடிக்கல் காலேஜ் வந்து தஞ்சாவூரில். இட் வாஸ் எ வெரி சிம்பிள் கேஸ். ஃபார் 8 year old சைல்டு, ஷார்ப்னஸோட சைல்டு, போஸ்ட் ஆப்ரேட்டிவாக 1 hour கழிச்சு பேபி அழ ஆரம்பிச்சிருக்கு. ஷி டெவலப்டு ஃபிட்ஸ் அண்ட் டைடு. ஸோ பிஃபோர் அட்டெண்டிங் பேபி டைடு. And because it stops child, postmortem was done, found to be a AV malformation in the brain. So there was some rupture. Because of the cry, intracranial tension increased and there was some rupture. So for a small tongue tie, around the சின்ன கேஸ் ஒன்றும் பிரச்சனை இல்லை, சொன்னால் பண்ணிடலாம் அப்படின்னு நினைச்சது. It end on in the death. So 2 + 2 is equal to 0. அதே வந்து ஒரு பாலிட்ரோமா வந்து அட்டன் பண்ணுறாங்க, ஒரு 2 பக்கம் ஐசிடி டியூப் போடுறாங்க, ஸ்ப்ளீனெக்டமி பண்ணிட்டு கிட்னி இன்ஜுரி, மல்டிபிள் இன்டெஸ்டினல் இன்ஜுரிஸ், மல்டிபிள் அனஸ்டமோஸ் இந்த பக்கம் ட்ரைவ் வச்சு எல்லாம் பண்ணி ஒரு 4 பாட்டு பிளட் இருக்கு ஆதரவோட பெயினோட அடிச்சுட்டு போட்டு நான் சொல்றது ரொம்ப நாள் முன்னாடி. ஸோ இது வந்து வெயிலால் 3 மணி 4 மணி வரைக்கும் சர்ஜரி பண்ணிட்டு சரி இப்போ வச்சா பார்க்கலாம் அப்படின்ட்டு அடுத்த நாள் காலையில் ரவுண்ட் சொல்லும்போது இந்த பேஷண்ட் நல்லா தெம்பாக உட்காந்து குட் மார்னிங் சார் அப்படின்னு அந்த சீஃப் சொல்கிறார். ஸோ இந்த கேஸில் வந்து 0 ஆகிடுன்னு அவர் நினைச்சாரு. அதில் 2-3 வரும் அப்படின்னா பட் ஹி எஸ்கேப்டு. அதில் 2-3 வரும் அப்படின்னா பட் ஹி எஸ்கேப்டு. ஸோ வாட் ஐ வாண்ட் டு சே இஸ் மெடிக்கல் சயின்ஸ் இஸ் ஸோ காம்ப்ளெக்ஸ். மெடிக்கல் சயின்ஸ் இஸ் இட்ஸ் human body is like another complex machine. It is very difficult for even doctors and scientists to understand about the disease course because there are inherent ischemia drug, inherent ischemia procedure, inherent ischemia surgery, inherent ischemia, inherent complication here. So all these things are already, even though we explained in detail before getting an informed consent, people go for litigation. For example, வந்து கோவிட் கேஸ் நிறைய வந்திருக்கு. 2 வருஷம் முன்னாடி கோவிட்ல வந்து எல்லாரும் நமக்கு மலர்லாம் போட்டாங்க, அலிகாப்லாம் மலர் போட்டாங்க, மணி அடித்தாங்க. ஆனால் வந்து இப்போ 2 வருஷம் முடிஞ்சோன்னா லாட் ஆஃப் கேசஸ் சார் கோவிடுக்கு 4 லட்சம் 5 லட்சம் 10 லட்சம் கோவிட் நிறைய கேஸ் வருது. அதனால் I request the members who are already not a member of DMCH to become member and get yourself protected. And also hospital protection, you can get your hospital in the fold of hospital protection scheme. And there is a family benefit scheme where you can get the medical claims expenses up to 60,000 per hospitalization for 1 year, maximum 1 lakh medical. Thank you for the opportunity.
Vote of thanks to President-elect, our Speaker, Muthukumaran sir, for the lovely talk, our past presidents, senior doctors, dear members, friends. and the audio visual. This video is going to be on YouTube IMA Salem 2022. It is being recorded and it will be posted. Even your video will be posted as BPLS's talk, sir. You can send it to your head office. Thank you, one and all. We can join for dinner, sumptuous dinner from on time. Thank you.